Good day and welcome to today's Medicaid coverage of asthma self-management education, analysis of services, providers, and settings call. At this time, all participants are in a listen-only mode. If you'd like to ask a question, please enter it in the Q&A box on your screen. It is now my pleasure to turn the conference over to Ara Janoyan. Please go ahead.
Great, thank you. On behalf of the American Lung Association, we thank all of you for joining us on our webinar today. This is a great opportunity to engage with diverse stakeholders and to discuss the importance and ways to improve coverage of asthma self-management education for those living with asthma and Medicaid. We'd like to take this opportunity now to introduce today's speakers. I'm Ara Janoyan. I'm the Director of National Health Policy with the American Lung Association. I engage in the Lung Association's policy initiatives surrounding Medicaid, Medicare, and ACA implementation for asthma, COPD, and lung cancer. And I also manage the Asthma Care Coverage Project. And I'll let Katie Horton introduce herself.
Hi, this is Katie Horton. I'm a research professor at George Washington University, School of Public Health and Department of Health Policy. And I worked with Ara on this analysis. I had a team here at GW, and looking forward to sharing the results today.
Great, thank you. And we're happy to have Katie here and all the work that her and her team have done on the issue brief. And so next, I would like to just give a broad overview of today's webinar. Just start off with background information on self-management education, its components, as well as what the state Medicaid coverage landscape is based on the Lung Association's findings through the Asthma Care Coverage Project. And then we'll go into the 10-state Medicaid coverage analysis and recommendations with Katie. But before we move on, I just want to make just one side note that this issue brief was supported by grant number 5U3-802-000224-04, a grant-funded project from the CDC. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the Centers for Disease Control and Prevention or the Department of Health and Human Services. Thank you. So, asthma self-management education has a variety of components, and we've provided them here in the next two slides. While asthma cannot be cured, it can be self-managed with access to necessary care and proper resources that will empower the individual and their families to improve their health outcomes. Self-monitoring asthma includes understanding asthma, recognizing its signs and symptoms, and identifying factors that worsen one's asthma. Medication adherence and proper intake is to ensure that the patient uses the right asthma medicines at the right time and in the right way. Written asthma action plans should be patient-centric, culturally and linguistically appropriate, and provide a roadmap for daily management of asthma symptoms. It is also important to take into account patient comorbid conditions that may impact their asthma management. Environmental trigger assessment and reduction can either be focused on triggers in the home or on how to avoid triggers in public settings. All of these components, to note, rely on working with an asthma care provider to assess and monitor your asthma every 6 to 12 months, and more often if you have symptoms. And here we have the components of self-management education as it relates to the importance of clear, open communication and engaged, proactive collaboration among both the patient and provider to help improve patient health outcomes. Health providers may include asthma educators, respiratory therapists, nurses, physicians, and pharmacists. Patients and providers across the spectrum of care in a variety of settings must work together to ensure that the best asthma education strategies are integrated and work best for the nature and severity of the patient's asthma condition. This collaboration should be continual, not only across the various points of care, but also on an ongoing basis at any point of care in order to adjust the methods of the patient's management of their condition based on how change in symptoms or medications may occur. And millions of Americans, including a significant number of children living with asthma, it is imperative to ensure access to treatments and services that will help reduce the burden of asthma and improve asthma health outcomes. Here we can see the impact that the burden of asthma has on hospitalizations, school absenteeism, and a health system's perspective given the prevalence of asthma in Medicaid populations. And with that need to address the gaps and deficiencies in guidelines-based care in Medicaid, we'd like to now take this opportunity to briefly describe the coverage landscape of asthma self-management education. The Lung Association has long recognized the importance of adherence to best practices in reducing the burden caused by asthma. The Lung Association strongly supports and believes that care for asthma patients should be based on the recommendations in the National Asthma Education and Prevention Program Expert Panel 3 report, or NAPP report, which are provided here in sort of broad categories. Given the burden of asthma and its prevalence in Medicaid, which I previously described, adherence to evidence-based care will help reduce the burden of asthma on individuals and their families. Now, despite the evidence-based guidelines for asthma care, there is still a gap as to what is actually being covered in state Medicaid programs. The Lung Association's Asthma Care Coverage Project tracks coverage and related barriers to asthma guidelines-based care in state Medicaid programs. Here you'll see a list of the 7 categories of care that the project tracks, which includes part of quick relief medications. There are 4 quick relief medications and 20 controller medications, as well as for the medical devices, which include nebulizers, peak flow meters, and valve holding chambers. A key component of asthma management is self-management education, which essentially encompasses all prior categories of care through empowering individuals and families on how to use their medications and adhere to treatment plans, as well as addressing asthma triggers as mentioned before. And the following is simply a list of the barriers that the Asthma Care Coverage Project tracks, along with the coverage categories listed before. And the relevant barriers are applied to each of the 7 categories of care being tracked. Now, this map describes the extent of coverage across the 23 states that were then funded by the CDC National Asthma Control Program in 2016, and which remains so as well today. Please note we are currently updating these state data, as well as gathering the remaining states, District of Columbia and Puerto Rico, all of which will be available in the next couple of weeks. Map does show that 5 states of the 23 appear to have no coverage, but we do have 5 red states that offer, 5 states in red that offer self-management education without barriers. The remaining continue to have coverage varying among the state Medicaid plans. And once more, this is information based off of FY16 data, and this information shows that it is evident that there is a lack of uniform and consistent coverage, not only within states but also between states. And it is important to understand the nature and extent of asthma self-management education in the states for which at least some coverage exists. And with that, I'd like to turn it over to Katie Horton, who will provide us more information on the in-depth analysis that she and her team undertook to address the types of services, the settings, and providers surrounding self-management education.
Thank you, Ara. Our project analyzed Medicaid coverage of asthma self-management education in 10 states. This analysis was based on the recommendations by the 2007 NAEPP guidelines. Highlighted on this map, you'll see the 10 states we selected. These states include Connecticut, Indiana, Maine, Massachusetts, Ohio, Rhode Island, Montana, Utah, Vermont, and Wisconsin. These states were selected in part because they showed some variation in coverage of asthma self-management education based on the American Lung Association review that Ara mentioned previously. We had 3 areas of analysis for this report. The kind of asthma self-management education services that are available to Medicaid beneficiaries would be the first one. The second, the range of providers delivering these services. And the third, the variety of settings in which these services are being provided. For each area of analysis, services, settings, and providers, we looked at 3 distinct things. We described the relevant section of the NAEPP guidelines. We outlined relevant Medicaid law in the report, and we presented findings on the coverage landscape for asthma self-management education in the 10 states. In terms of methodology, there's an important limitation. We only included information that we obtained from publicly available plan documents. These are documents we were able to access through the internet. We analyzed 47 Medicaid plans in the 10 states. The examples of publicly available documents that we reviewed included things like member handbooks, provider manuals, health management program descriptions, and other relevant materials found on the internet. And it is important to note that while we're reporting on what we found in these documents, some plans might provide asthma services, education services, without mentioning them in their public documents. So again, we are reporting only what we found in the documents. One other important point, the managed care plan documents don't specify whether the asthma education services they offer are reimbursed through Medicaid or through an MCO's administrative budget. We know that many health plans are doing good work in this area, and many of them are covering these services through their administrative budget, although we did find that many of the plan documents were not clear about how these services were being reimbursed, if at all. The first area of analysis in terms of services, the guidelines note that asthma education must begin at diagnosis and continue through follow-up care. It recommends, they recommend a multifaceted approach, including provision of asthma information and training and management skills, self-monitoring, and development of an asthma action plan, among other things. In terms of services and the findings, we did find that many health plans offer asthma education services as part of their disease management program. A plan document might use many terms for disease management program interchangeably. For example, care management, population health program, wellness program, or health education program were terms that we came across in plan documents. We note in many of these plans we found descriptions of standalone asthma education services outside of a disease management program, things like a community wellness initiative or group classes. And only a few plans provide details about the type, frequency, and duration of asthma education services. I think that was quite surprising to us in terms of the lack of full descriptions about what is offered in this area. In addition, majority of plans reviewed were not very specific about which services are billable. It's because asthma education services generally take place as part of a broader disease management program or as part of a general wellness visit, it's hard to say whether these services are being billed for individually based on plan documents. For example, only 2 plans describe CPT codes and related services that are covered in our review. These are some of the reimbursable billing and procedure codes that were found for asthma self-management education in the 2 plans that we identified. They include individual preventive counseling services, codes for group preventive counseling services, group education services, preventive care, and inhaler technique. We organized the services found in plan documents into 6 different categories. The first is clinic-based asthma self-management education services, and 8 out of 47 plans reviewed offered services like asthma disease management programs that provided education about asthma management and medications through a doctor visit. The second category, home-based asthma self-management education services, 6 out of 47 plans noted this and described services such as in-home asthma education programs typically offered and provided by nurses. The third category, home environmental assessments, 5 of 47 plans offered this and included things like asthma education and or environmental assessments in the home setting. In terms of telehealth services, our next category, 11 of 47 plans typically involved services that offered, things like 3 to 6 sessions of health coaching over a telephone. The 5th category, educational materials by mail, 9 out of 47 plans provided detail about services related to a disease management program, including a series of educational mailings. And then the final category, asthma education classes, 8 out of 47 plans included information about asthma education classes as part of its asthma education management program. Okay, so let's look at the second category, providers, the second category of our analysis. Asthma self-management education, it's noted in the guidelines that education should begin at the time of diagnosis by a physician and be reinforced by all health professionals across the care continuum. The guidelines note the use of both traditional and non-traditional providers should be able to deliver asthma self-management education services, including physicians, nurses, respiratory therapists, pharmacists, community health workers, and certified asthma educators. As we look at providers, we want to note that CMS gives states broad discretion to recognize and potentially reimburse a broad range of licensed health professionals. There was a recent Medicaid change that I'm sure many of you are aware of. We call it the Medicaid Preventive Services rule change, which allows states to reimburse non-licensed providers for preventive services. Providers must be recommended by a physician or another licensed practitioner. And I think, what we see across the states is that, a number of states are still working on determining whether and how to implement this rule change in their fee-for-service programs. It does require a state plan amendment be filed with CMS. Under this rule change, the states will retain authority to define practitioner qualifications, ensure appropriate services are being delivered by qualified practitioners, give states the ability to define the preventive services being provided, and to describe the reimbursement methodology. It's important to note that the rule change only addresses the who. In other words, the practitioners have changed, not the what or the services. Preventive services must be medical, remedial in nature. That doesn't change. Must involve direct patient care and be for express purposes of diagnosing, treating, or preventing illness, injury, or other impairments to an individual's physical or mental health. So things like non-medical preventive services aren't covered, like smoke detectors, for example. And should be important to know that managed care plans, even if this state plan amendment has not been filed, they still have the discretion to hire non-traditional providers like community health workers as internal staff using their own administrative budgets. In terms of providers, what we found in plan documents, the number of plans covering the type of provider for asthma self-management education. In terms of nurses, we found 24 of 47 plans analyzed covered them or included them in their descriptions. Respiratory therapists, 2 of 47 plans. Pharmacists, 4 of 47 plans. Community health workers, 4 of 47 plans. And asthma educators, 5 of 47 plans. Finally, let's look at settings as our third category of analysis. In terms of the NAEPP guidelines, the guidelines state that asthma self-management education services should be provided in both clinical and non-clinical settings. So clinical settings like physician offices, community health centers, hospitals, et cetera. Non-clinical settings including homes, schools, and community locations. Each setting can contain different providers, may contain different providers or resources, may reach patients at different points in their care. The guidelines make recommendations on the general types of asthma self-management education that should happen in each care setting. So just to give one example, in the home setting, the guidelines state that home-based asthma self-management education should supplement and reinforce clinical disease education and treatment by reaching individuals where they live. Specifically, the guidelines recommend that home-based asthma education be delivered for children to improve family understanding of asthma and include allergen control education. The guidelines note that allergen control education in the home setting can lead to reductions in ED visits and improvements in quality of life for caregivers. So in the 10 states we reviewed, asthma self-management education services really are most commonly offered in clinical settings, and we heard this time and time, or saw this time and time again in plan documents. Other settings that were described in plan documents include pharmacies with a mention of mentioned in 2 out of 47 plans, the home setting, 6 out of 47 plans, and the community setting, 10 out of 47 plans. Finally, we took a closer look at Indiana. We knew that this state had a well-organized coalition, and we were interested to see what we found in terms of whether plan documents really reflected what was happening in the state. We were only able to look closely at one state through a series of interviews, and Indiana served as a good example for us. We reviewed Indiana Medicaid plan documents, including member handbooks, provider manuals, etc., and in addition, conducted interviews with INJAC, or the Indiana Joint Asthma Coalition, state Medicaid officials, and Parkview Health Asthma Callback Program. Parkview Health is a health system with not-for-profit health system with 9 hospitals. So Indiana requires that managed care plans offer chronic disease management programs and encourages them to comply with national guidelines. But it's clear that they don't specify the types, frequencies, or duration of services that have to be provided. Indiana Medicaid interviewees stated that Indiana does not offer reimbursement for asthma education procedure and billing codes because these services generally take place in annual wellness visits. Indiana has not yet determined whether and how to implement the Medicaid Preventive Services rule change I described earlier, but INJAC and other stakeholders in the state are actively considering this opportunity. And then finally, while Indiana Medicaid reimburses for services in home settings, it only reimburses services provided by certain types of traditional or licensed providers, such as nurses, qualified home health aides. It's important to note that we were unable to interview any of the managed care organizations in Indiana directly, but based on plan documents, it appears that Indiana managed care plans provide chronic disease management programs as required by the Medicaid office, but the scope of these asthma education services provided through these plans vary quite a bit. And that variation includes things such as education as part of a disease management program or perhaps a health education class. Plan documents do not describe the range of providers eligible to perform asthma-related services. It was really difficult to assess this element. But we were able to, I think, look at some important lessons coming out of Indiana. Certainly building strong coalitions, and I know many of you on the phone will be very familiar with some of these lessons learned, but building strong coalitions seemed to be incredibly important to convening various stakeholders and advancing conversations around policy. INJAC, as mentioned earlier, it's a voluntary network of stakeholders and organizations, includes folks from government agencies, professional organizations, managed care plans, hospitals, schools, etc. In our talks with INJAC and our interviews with INJAC, they really emphasized the value in bringing these various stakeholders together. INJAC has a number of working groups that include Asthma Educator Reimbursement Work Group, an Asthma Team-Based Care Work Group, and an Environmental Work Group, among others. And it seems that this coalition really has proven to be an effective tool for improving asthma initiatives in Indiana. Other lessons, the importance of demonstrating cost effectiveness. We heard that over and over again. INJAC stated that cost effectiveness is the key factor for Indiana Medicaid and MCOs in determining coverage. Demonstrating return on investment of asthma self-management education, it can be done in a variety of ways, including highlighting outcomes of successful programs in the state or lifting up examples from other states. For example, Parkview Health and the Asthma Callback Program in Indiana includes follow-up phone calls and home visits delivered by a team of providers, including registered nurses, certified asthma educators, and respiratory therapists after an individual is admitted to the hospital emergency department. A third-party evaluation of this program found reduced emergency department visits, increased number of participants with a regular source of primary care, and improvements in missed days of school and work. So by calculating the ROI for example, this program would be very helpful in helping policymakers and others determine where to make investments and how to target proposed initiatives. Another key takeaway in the importance is to really engage these multiple stakeholders, especially managed care organizations. NJAC interviewees stated that it's important to pull in the Medicaid office folks routinely, building those strong relationships, to further develop relationships with managed care organization leaderships, and trying to figure out who are the appropriate contacts can sometimes be difficult. Sometimes it differs plan by plan. We heard about, for example, points of contact at certain plans would be a community engagement staff, while at another plan it might be a medical director or an individual in charge of the chronic disease management program. But really just, this coalition continuing to serve as a catalyst for managed care plans to provide evidence-based asthma services. We heard loud and clear as a very important takeaway. So to wrap up my part of the webinar, I think that the 10-state analysis absolutely identified gaps in Medicaid reimbursement for asthma education services, the providers who deliver them, and the settings in which the services are delivered. Clearly, at least based on publicly available documents, it doesn't appear that evidence-based guidelines for asthma self-management are being implemented fully. Interviews with stakeholders in Indiana certainly shed light on how these gaps can be bridged by multiple stakeholders working together to advance evidence-based care. And so, Ara, I think I'll turn that back over to you for some additional thoughts.
Great, thank you. And we'll be going now to the set of recommendations, and this will be, again, just sort of recapping what Katie had described through the three categories that they had researched in the issue brief. And as noted, of course, self-management education empowers patients to proactively manage their asthma symptoms. And despite the important role that it plays in helping patients control their disease, many patients do not receive adequate education due to the lack of coverage for these services. And so there is a need, as noted earlier, for consistency in coverage for self-management education services. There's also a need for transparency. Patients need to know whether asthma self-management education is available and what types of services are covered in order to best use these services. State Medicaid offices and MCOs have the opportunity to address these gaps in coverage and transparency. Coordinated efforts can help expand asthma education services, settings, and providers. And so the following recommendations based on guidelines to strengthen those sort of two paths of consistency and transparency. And for expanding services, plans should align services with these evidence-based guidelines for asthma care to strengthen the services that will lead to better patient outcomes. Plans should publicize the asthma education services offered to ensure open dialogue with patients and providers regarding covered services. Plans should adopt clearer reimbursement pathways for providers to better provide these services, whether clear disclosure of billing and procedural codes or integrating services within administrative budgets. And for expanding providers, non-clinical providers can reach a wider audience of Medicaid patients than clinicians alone. Expanding the reimbursement to non-licensed providers such as community health workers and asthma educators, and investing in a robust community-based workforce can provide a wider range of asthma education services. And establishing Medicaid health homes to bring teams of providers together can also offer comprehensive care coordination. For expanding settings, offering a wide variety of settings, of course, beyond the clinic, will expand the reach to the patients. Having them offered without barriers will further ensure timely access to needed care. And as Katie had mentioned before, the additional settings include the schools, homes, communities, pharmacies, et cetera. And so for now, we'd like to open it up to Q&A. I know, I think the moderator would like to direct where to submit your questions. Well, you can feel free to place your questions into the Q&A box, should appear on your right-hand side. We do have a question about this information. Again, will be posted on our website in the coming days to review the slides and to review the webinar. Question came up with regards to the initial map that was shown with only 23 state data. Once more, that's information based off of our data collection last year. We currently have our near completion for collecting the remaining 27 states, DC and Puerto Rico, and all that information will be available on our website in the coming week or so. And
there's more questions coming in. Feel free to submit your questions in the Q&A box. There was a question about what is a good way to get in contact with asthma educators. A couple ideas: so your local asthma coalition, your local American Lung Association. Also, the Association for Asthma Educators has a number of asthma educators on board. And the National Asthma Educator Certification Board certifying body does list the number of people who pass the exam. So that's a way. And by the way, my name is Barbara Kaplan. I'm the National Director for Lung Health Education.
yeah, Kate, there was a question about what's the best way to obtain the state plan amendment.
Sure. So several states have been working on filing a state plan amendment. It has to be formally submitted from the state Medicaid office to CMS. Typically most states are bringing in stakeholders. Most state Medicaid offices are bringing stakeholders together to think about what that state plan amendment should look like, what it should include in terms of defining the various elements I described earlier, who they want to include in terms of reimbursing, what, so bottom line, it has to be submitted by your state Medicaid office, and a first step would be to reach out to them and encourage them to create a working group to consider this policy change.
The Kendrick gets reimbursed. I think there was a question on clarity on reimbursement about who gets reimbursed. I know that Katie, you mentioned a set of billing and procedural codes that you had come across. So if you'd like to address that question to clarification as to who specifically gets reimbursed.
Sure. So I think we're talking about at least two different things. States currently can use administrative dollars to reimburse for non-traditional providers, folks like community health workers. So there's some ability on the plans side to use certain providers and reimburse them. Secondly, state Medicaid plans, there are a variety of codes, both state, local, and even federal, that would help define those services. So if you had a billing code, then various entities and providers could file for reimbursement through those codes.
And there's a question here about the 47 plans. Katie, if you can go into more depth as to whether the 47 plans included all the Medicaid managed care organizations within the 10 states.
Yes, they did. So, for example, one state might have 3 health plans in their state delivering Medicaid services. Another might have 7. We did include fee-for-service as a plan for each state as well.
Oh, and there was a question on how the asthma self-management education codes were, I know you mentioned that some may not be reimbursed, or there's, in your presentation about the reimbursement in Indiana, sorry, specifically the case study in Indiana, and whether, what the difference is between the reimbursement for those or for the wellness visits.
Yeah, so what we heard through our interviews is that there aren't specific codes for asthma self-management education. Instead, some education often happens in a wellness visit, and that wellness visit is reimbursed instead of an individual service related to asthma self-management education.
And there's also an additional question on partnerships, and I know that it speaks to the case study that you had done, Katie, on Indiana with regards to coalitions. And so question poses to the partnerships with Medicaid to approach it best at the local or state level, given your analysis.
If I understand the question correctly, is it how do these coalitions develop, and where do they target, state or local? Is that what we're asking?
Correct.
Yeah, I think in the case of NJAC, we heard that they have a very big tent available for a variety of stakeholders to come together and work in different work groups, and that they are advancing policy and education and information on various levels, both the local and state level.
Okay, great, thank you. And if there are any additional questions, feel free to enter into the Q&A box.
Hi, this is Barbara again. There was a question that came in about the American Lung Association currently has any offices that submit for and receive reimbursement for asthma education, and I don't believe, I do not have any knowledge of that happening at the state or local level.
Okay, well, at this time I'd like to thank everybody for joining today's webinar. I want to take the opportunity to thank Katie and her colleagues at the Milken Institute School of Public Health at George Washington University for taking on the issue brief and for participating in today's webinar. We respectfully thank all the time and hard work you and your team have done for the issue brief, and all those who participated in the interviews as well. We thank you all. Just as an upcoming webinar on June 28th, the Asthma Care Coverage Project will have a webinar on the information based on this year's findings, which is a comprehensive nationwide, sort of the first ever availability of nationwide comprehensive analysis on state Medicaid coverage for guidelines-based care. And so we'll go over that information and our findings. And the issue brief that we discussed today will be published in the coming weeks, and you can reach back out, or our contact information will be available at the end of the presentation, but you can always visit. It'll be published on our website at lung.org/asthma care coverage. And with that, I just want to say thank you again, and please reach out if you have any questions to either me or Katie.
And this concludes today's program. Thank you for your participation. You may now disconnect.